Okay, good afternoon, everybody. I'd like to welcome all of the participants who are joining us online. I know that people are still trickling into the audience room, and we're going to take a couple minutes with our introductions so that as people come into the room, you're not going to miss our speaker. I'd like to start off by introducing myself. My name is Warren MABEE, and I am the director of the School of Policy Studies. And it is my pleasure to welcome you to this very special and virtual session of the Duncan Sinclair Lectureship. Before I begin the lecture, I'd like to take a moment to acknowledge the fact that Queen's University is situated on the traditional territories of the Haudenosaunee and the Anishinaabe peoples. Now, given the virtual setting that we're in and the fact that we are scattered from coast to coast to coast today, you will be situated on many different traditional territories, and I'd ask that you take a moment and remember that and think a little bit about that connection. It is our privilege to be able to study here, to learn here, and to have this discussion here today. I am delighted to be able to welcome you to this edition of the Duncan Sinclair Lectureship. And I'll say a couple words about the lectureship itself and about Duncan Sinclair just to kick us off. So the Duncan Sinclair Lectureship is housed jointly between the School of Policy Studies and the Health Services and Policy Research Institute at the Faculty of Health Sciences here at Queen's University. And it recognizes the tremendous contributions of our friend and colleague, Duncan Sinclair, who is in attendance today. Many of you on the line today will know of Dr. Sinclair's accomplishments. He is a past Dean of Arts and Science, a past Dean of Health Sciences, a past Vice Principal here at Queen's, a recent appointee to the Order of Canada. He has been a tremendous friend to the School of Policy Studies, and I'll say personally a great friend and mentor to myself. And I'm really delighted that we have this lectureship to be able to celebrate his contributions. And I would point out that we're very grateful for the contributions of the Medical Research Council and the Faculty of Health Sciences, as well as the Sinclair family, who have provided the funds that make this lectureship possible. So thank you to all of those contributors. We have many participants online today, and I'm delighted that you've chosen to take an hour and a half out of your day to be with us. We're using Zoom webinar as our tool today, and the Zoom webinar has a nice feature. When you move your mouse around on the screen, you will see a button called Q&A at the bottom of the screen, and that is where you have the ability to ask questions, and those are the questions that we will work through at the end of this lectureship. So if you have questions as you go, you can feel free to put them in to that Q&A function. We are also welcoming a number of people who are watching this lectureship on YouTube, streamed on YouTube. You don't have the ability to pose questions there, but I hope that you enjoy this lecture. To introduce our honored guest today, I want to turn over to my colleague, Dr. David Walker, former Dean of Health Sciences and former Director of the School of Policy Studies. David, I'm going to hand over to you. Thank you so much.
Thank you very much, Warren. I'm just delighted to introduce this year's distinguished Sinclair lecturer. Our guest, Bonnie Henry, joins the company of previous speakers, including David Naylor, Daniel Martin, Jeffrey Simpson, Eleanor Kaplan, Andre Picard, and the Honorable Jane Philpott, who is now Dean of Health Sciences at Queen's. Our very special visitor today is the Provincial Health Officer for the province of British Columbia. Bonnie's career extends from the Maritimes and Dalhousie after a brief time in Kingston in high school, I just discovered, through a Master's of Public Health and residency in preventive medicine at the University of California, San Diego, and University of Toronto, through the World Health Organization and UNICEF, working in Pakistan and Uganda, to Toronto Public Health, just in time for SARS and the subsequent Seven Oaks nursing home where we investigated together. Then to BC as Deputy and now Provincial Health Officer. Bonnie's expertise is undoubted. Her navigation of a pandemic has been remarkable, and her lucid, firm, sensitive, and compassionate decisions and communications have been critical and acclaimed. I'm just delighted that she had agreed to share some time with us today. Dr. KIERAN Moore, my colleague in the Department of Emergency Medicine, who happens to be our Regional Medical Officer of Health and Queen's Professor, is a close colleague of Bonnie's, and we were delighted when she agreed to our request to present this year's Sinclair Lecture. KIERAN will moderate questions after Bonnie's address, so we look forward to those. So Bonnie, welcome to Queen's that you see in my background, sadly rather vacant. We look forward to your presentation on balancing vaccine hope with pandemic reality.
Thank you so much. And it is a tremendous honor to be here with you today. And I want to start by recognizing that I am on the traditional and unceded territories of the Lekwungen speaking people here in Victoria, BC. That's now the Songhees and Esquimalt First Nations. And I am very grateful to be able to speak to you from the traditional lands of these peoples. We talked several months ago about this lectureship, and many months ago, actually, at the time when, I think many of us thought perhaps we would be at the downside of this pandemic. And we still did not have vaccine on the horizon. But as we caught up, Dr. Walker and Dr. Moore and I had a discussion about a topic a few weeks ago. We realized that this is a different and probably a most challenging time that we are in right now. And so we decided to talk about balancing what I call vaccine hope with pandemic reality. And the reality that is sometimes exhausting right now. And I've said many times here in BC that we're in this place of challenge and hope, because vaccines are an amazing bit of hope, but they're not yet here for all of us. And we need to rise to that challenge of getting through this next few weeks and months. So I was thinking a lot about, how did we get here? How did we get through this past year? And for KIERAN and some of my colleagues across the country, it's been over a year, because we really started to worry about this new virus in the end of December in 2019. We had heard some rumors before that, but I was having flashbacks, and I know anybody who was involved with SARS in Toronto was as well, when we started hearing atypical pneumonia in parts of China, because that's, for those of us in the medical world, that's code for an infection that's causing severe illness in the lungs, and pneumonia, that we don't know what's causing it. And since the SARS outbreak in Toronto and around the world in 2003, China had done a lot of work on coronaviruses and on influenza. And so the fact that there was a virus that they didn't know what was causing it was really concerning. And unfortunately, that turned out to be true. It has been in many, many ways an extraordinary and incredibly challenging year. All of our normal rituals have been rent asunder, and changes in our lives that we probably, even those of us who have been thinking about pandemics for many years, had never really thought that we would shut down society in the way that we've had to do, that we would be wearing masks everywhere again, that would become a habit. And I don't know about you, but now when I watch something on television or a movie where people are actually together and hugging each other, it makes me cringe a little bit. And so, but it's that pre-pandemic thinking, and how do we get back there? So I've thought a lot about, where have we come and what have we learned through this time? Who knew a year ago that we would have seen so much change and that we would learn so many things? It certainly has told us that we are connected in a global community in ways that I believe many of us never really realized. What happens in a province in China that most of us had never heard of before matters to us. What happens with the supply of gloves and gowns and masks and N95s matters to us. The fact that vaccines are being produced in countries other than our own matters to us. And of course, those proximate things, what's happening next door to us in Washington State matters a lot early on when we were starting to get introductions into our communities. It matters what happens in Iran and the fact that we found a virus here in BC before they even realized they were having these outbreaks in Iran. I think there's also things that we have learned that words matter and how we communicate about what's going on matters as well. And we have changed many things in our lexicon over the last year that have taken on new importance in many ways. And we've exposed some of the inequities in our society and our communities that were always there, but were never important enough until they were revealed, the impacts of this pandemic. I have said many times we're all in the same storm globally, but we are not all in the same boat. And we have seen that over and over again, whether it's racialized people, Indigenous peoples, certain countries, certain communities around the planet have been disadvantaged more than others. We've also seen, though, altruism and heroism in many ways, even simple acts that we do to each other, for each other in our community, and that we know that the things that we're doing together make a difference. And we bend our curve, not the rules, things that we say here to help us through this. It brings out the best and the worst of people. We've learned that, you know, some people's reactions to uncertainty and fear lead them to lash out, to be angry. Some people blame and scapegoat, and we still see that. There's still blaming, whether it's blaming people for getting sick, blaming people for not wearing masks, blaming people for breaking the rules. And sadly, we've seen as well targeting of different groups, othering. And in some ways, we've seen that as people's reactions to the uncertainty and the fear and the anxiety. But thankfully, we have also seen altruism. We've seen people dropping off food, looking after other people's children, supporting food banks across the world. And we know that we have created connections in new ways like this. I would love to be there in Kingston with you right now, but I'd be hard pressed to stop hugging my friends and colleagues who I haven't seen for such a long time. But I think of all of the new lexicon that we've learned as well. Words like epidemiological curve roll off the tongue now. Who knew that? Who knew the work that we do as epidemiologists would actually be okay and kind of fun? Things like contact tracing take an overwhelming importance. Non-medical masks, who we identify as essential workers, more than just healthcare workers, policemen, but also our grocery store clerks, truck drivers, garbage collectors, people that we realize are essential to our functioning. The word PPE, I remember the first time I used it in a press briefing, and the Minister Diggs said to me, "Oh, you better say what, people won't know what that means." I mean, who doesn't know what PPE is now? Bend the curve, lockdown, 2 meters or 6 feet as we still seem to use more frequently. Things like social, or now physical, I prefer physical distancing. Things like bubbles, Zoom, who even heard of Zoom before last year? Quarantine, nasopharyngeal swabs. Okay, that might be just me. The value of toilet paper, remember that? And we've learned, of course, simple things like you should never, ever do your own hair in a pandemic. And I understand, David, that you'll be able to overcome that one very soon in Kingston. We've learned in a crisis, though, that we can be reliant and resilient and adaptable, even when it's hard. And now is the time when it is more difficult than we even could have imagined. So we are at a point where we have vaccines, and it is almost a miracle in many ways. So we have added to our lexicon with a whole variety of words around immunization and vaccines. And it's interesting because those of us who've been working in immunization worlds for many, many, many decades even, you know, these are words that roll off our tongue. Things like AFI, adverse events following immunization. Things like what types of immunization programs do we have? Things like cell-mediated immunity, like antigen levels. And now, of course, our new vaccine platforms. So we've come to a place in our pandemic where we have a miracle almost. It's hard for us to believe that we can have vaccines that not only are new and new platforms and were developed and tested rigorously with phase 3 trials within 9 months of the virus being identified and the genetic code being out there. It really is miraculous in many, many ways. And it tells us what we can do with that connectedness when we do work together and we're not competing with each other to share that scientific knowledge and expertise and that research knowledge, to share it widely together and in a community around the world. And I think that is something that I hope we will continue in the future. So things like now entering our lexicon, messenger RNA. I remember the first time I explained, this is a new platform, and it's really this very delicate piece of the genetic material that tells our body how to make that antigen, that protein, that spike protein, so that our own immune system can recognize it and protect us if we're exposed to the virus in the future. The fact that it's encoded with a lipid nanoparticle. So how do you describe that? That it's like soft tissue paper that holds this delicate package so it can be transported safely into our bodies. These are things that are amazing to us, these new platforms. And now we have viral vector vaccines, ones that have also been in the back of scientists' minds for many years and even decades, but now have come to fruition and are shown to work. And that's kind of exciting too. The fact that we have more than a dozen candidates, at least 5 of which have now been approved for use around the world, and more to come. Here in Canada, we have 2, both of them the messenger RNA vaccines, but we have a viral vector vaccine that is going to be approved for use, we think, very soon by Health Canada. But now we have a whole new set of complications. Who does the virus work best in? Where do we use it best? How do we get it to people? What about all of the things that are required to logistically get vaccine into arms of millions of people in our community? And how do we do that with the vaccine supply that we have and the uncertainty that comes with that as well? At the same time, how do we keep managing this pandemic that we are still in the midst of and that we're all really tired of? And when we think about public health, this is a very challenging time for us too, because we are still doing case management. Every single person who tests positive for this virus is being followed, at least in my communities. And we're doing contact tracing to more or less degrees, depending on how swamped we are with this virus causing infections. We're trying to understand where it is in our community that the virus is spreading now, because so many of us are doing what we need to do. We're staying away from others. We're keeping up our distancing. We're washing our hands. We're wearing our masks when we're in public. We're reducing our contacts, but still the virus is being transmitted. It's being transmitted in our workplaces when we let our guard down, whether that's a healthcare setting where we're meeting in the break room exhausted and taking our masks off at the most inopportune time, whether it's inadvertently passing it on to those that we need to carpool to work with because there's no public transit in the area where I live, and I work at a processing plant that provides food to our tables. That is the challenge that we're in right now. How do we make sure that we support each other now when we're all tired and we're a little bit cynical and we're a little bit afraid of what's going to happen? And then, of course, we're at that point where we've started to see these new variants of concern, yet another word to add to our lexicon of pandemic life. So these variants of concern are ones that we've seen cause havoc, even in countries that had been at that point of maybe being in control. So we're seeing them here now in Canada, whether they're the ones B117 that originated in the UK. We've seen the B1351 that's originated in South Africa. We've seen them in small amounts in dribs and drabs, but we're not actually testing systematically yet in the way that we need to. So we don't yet know the potential impact that they're having and what they might have in our near future. And we have another thing that we have learned, that modelers can be really helpful in helping us understand scenarios that can happen in the future. But some of those are really scary too. And the potential that could happen with these variants of concern is one that we're learning. And we're learning that the modelers are afraid. And sometimes we need to find data to help us understand where exactly we are. But again, it comes down to we're in this pandemic phase that we've not been through before. And we still have this unrelenting uncertainty. And how are we going to get through that when we still have, on the other hand, we have this hope, this light, these vaccines. So as we're trying to understand where we are with variants, where we are with transmission in our communities, we are also trying to understand how do we best protect people with vaccine? How do we find that race, that balance to protect people where we're, while we're still trying to understand where the pandemic is going next, where this virus is going next. And we need to look at where these vaccines work. One of the things that we have learned that I am so grateful for is that these messenger RNA vaccines work well in older people. We know that older people, our seniors and elders, have been the ones that have been differentially harmed by this virus, whether it's because they have more severe illness, whether it's because they're likely to die from it, more likely than younger people, or whether it's the impact of the public health measures that we've put in place that have meant many of our seniors and elders, whether in long-term care, whether in assisted living, or even living in the community, have been isolated in ways that many of them are finding challenging to even overcome. So that is our biggest challenge, our biggest concern. How do we protect our elders and seniors? And to have a vaccine that works in our elders and our seniors is the most important and wonderful thing that we have. So focusing on protecting them first, I think, has been our goal across the country. And that is the basis of the plans that most of us have rolled out. The challenge, of course, means how do we meet that demand with the vaccine supply? And our most discouraging few weeks that we've been through has been when our supply has been interrupted in the last 2 weeks, just when we were getting off and starting on this road. So our phase is here. We're talking about protecting the vulnerable and keeping our health system functioning. And those are the goals that we've had in this pandemic, but they're also the goals that we have for our immunization programs. And there are reasons for that. One is we know we can save lives with every dose that we give to people who are most vulnerable, but we also need to support the rest of our community. We need to know that snowy days, we're going to have car crashes, and we need to have the ICU beds in the emergency departments functioning to care for people who need it, whether it's a heart attack or slipping in the snow. So protecting our health system and protecting our vulnerable is the most important. But then what? How do we immunize people in a way that is equitable, that doesn't increase those inequities that this pandemic has exposed in our community? And it's a combination of how do we use the best vaccines for the right time, for the right people? How do we do this in a scale that we have not done before in this country, ever? We didn't have vaccines in 1918. So for us across the country, I think the the number one driving factor that leads to more severe illness and death is age. So all of us have developed programs that help us protect people who are oldest and most at risk first. But then we have to balance that with logistics. So these messenger RNAs, these amazing vaccines that work in older people so that we can protect you directly, they also come with a lot of caveats. They're very delicate, as I mentioned. They're like a delicate ornament wrapped in tissue paper. They need to be in freezers, -20, that one we can deal with, or ultra low temperature freezers. There's another word for our lexicon that require an infrastructure that we didn't have before, but now we do here across the country. That they come in pizza boxes of 975 doses that can only be reconstituted and kept at room temperature for 6 hours and need to be used right away. The logistical considerations that we have with these precious vaccines have been monumental in and of themselves. And now we have to deal with the concept of low dead space syringes. There's another word that those of us in the vaccine world knew about, but never really had to pay that much attention. But trying to explain to people why we're so fussed about these vaccines, the fact that the Pfizer vaccine is a third of a mil in a dose. That's a very small amount. And most of our syringes, the little line on the syringe is a 10% margin of error for those. And if we're going to get 6 doses out of every vial, which we absolutely need to do, we need to use the right tools to be able to do that and manage that consistently. And of course, who knew low dead space syringes are not readily available, and they are a hot commodity on the international market. Once again, we realize how connected we are globally with our supply chains, even for vaccines. Then we have newer vaccines, not yet approved for use in Canada, but where do we use these ones? Can we use the AstraZeneca vaccine, the viral vector vaccine, the Novavax vaccine, which is also another new, really cool, interesting one that's a baculovirus, but it's grown in moth cells. So it's actually, I guess, an organic vaccine, and it uses an adjuvant that's saponin from trees. And then, of course, we have our Canadian grown one, which is not on the horizon quite yet, the Medicago vaccine, which has also been one that's been under development for many, many years for influenza, that uses plants to grow up the virus so that our body's immune system can respond. So can we use these other vaccines that are thankfully more used to, they require logistics that we're more used to in the supply systems that we have. So things like they can be kept in fridges. Wow, that makes a huge difference when we're thinking about getting vaccines out to lots of people very quickly. All of these things, of course, are in this context of a misinformation and disinformation campaigns that are out there. It started with the anti-mask campaigns and the hoax campaigns, and now, of course, the anti-vax campaigns. So how do we make sure that we are monitoring for safety, for details of safety, making sure we know every single lot number of which vaccine has gone into every single person's arm? One, so we know whether they can get which dose they need for a second dose, but also so we can monitor for safety signals. And of course, we're all very concerned early on. The people that we're targeting for the first vaccines, these really effective messenger RNA vaccines, are healthcare workers and seniors and elders. We know that people in long-term care homes have other health conditions that are going to flare up or going to happen within timeframes of receiving vaccine. We know that healthcare workers, we need to monitor very carefully for safety to make sure that we have confidence in people being immunized. And that's scary. It's scary if you're the first one to get the vaccine in your community. And we have engaged with people around different communities, Indigenous elders, using the analogy of vaccine as medicine to support their community elders in being protected. These are all things that we have had to deal with in challenging ways. And even the concepts of the second dose and the interval between doses, and somehow the manufacturer's recommendations becoming the gold standard. But we know from immunizations, we know from everything we know about our immune system, that delaying for short periods of time in many cases provides you with a more durable and longer lasting protection. But these are things that we're learning as we go with this vaccine. Normally, when vaccines are approved, we have years of data to understand how long the immunity lasts, to understand if it prevents infection or just people getting really sick, ending up in hospital. So these are the things that we're learning as my friend and mentor, Dr. Sheila Vassar, said, you know, we're fighting the fire and building the bucket at the same time. And it's really challenging for people to understand, for us to say, yes, we think this is okay. The data tells us this, but this is what we know from everything else. And it's uncertainty, again, that affects us all. Right now, we need to buy time. So these are the things that I have been thinking about and my colleagues across the country have. We have an immunization program that's starting. It's stalling a little bit, but we know we are going to have more vaccine coming in the coming weeks, that we can get back on track to protecting those who are most at risk, and soon, but not soon enough, providing vaccine to everybody in our community so we can reach that point where the virus can no longer find unprotected people to transmit to. At the same time, we're seeing increased numbers of these variants of concern, and we've seen how they can impact communities, households, families, and whole nations. We only need to look to the UK, to Ireland, to Portugal, to states in the US to see that this rapid transmission can happen with these variants. So we need to understand where the variants are, how they're transmitting, how we can react to them and protect them. We need to buy time so that we understand the variants and we start to protect more people. And that is our dilemma right now. It feels like the whole world is tired. I know I am. Vaccine is our light on the horizon, but we are still in a long and dark tunnel. And this will be the hardest time. It will take the greatest toll on us now, personally and professionally, I think, for all of us. And now is where we must look to our own personal resilience, our psychological stamina, and how we can support each other to get through this phase. It's our perseverance and endurance that we need as a community, as a connected whole, to get us through this. And maybe even a little bit of soupçon, maybe, of defiance or outrage around this virus and how it has taken over so much of our world. We need that to counteract the darkness that many people are feeling right now. This feeling of unrelenting fatigue, and in some cases, the randomness of who is being infected and what community and how this virus is transmitting. We need to remember, of course, where we came from with compassion, that kindness that helps us understand that people are struggling and doing their best in the boat that they have been dealt with. We need to help use that to overcome the depression, the loneliness, the anxiety that so many of our family, our community members are feeling right now. I've used the analogy of an Ironman, and we are finally in the run, in the marathon, but we still don't know where the end is. And we don't know if this is a 42.2K or if it's an ultra. So we know, though, that both psychologically and physically, the last kilometers are the hardest for all of us. We need to remember this and give hope. We need to lift ourselves up again. We need to get our second wind, because there is an end to this, and that part is certain. part of that is, I believe, engaging with everybody, with our communities, with civil society, socially, about vaccine plans, about immunization programs. And there's been many discussions in my community about whether we need these mass vaccination clinics. But to me, they are a symbol, and they're a way for us to engage with society, to support. I am just waiting for the day that we will have the elders and seniors who live in our community coming to our clinics, being supported by community members, by volunteers, and then being immunized to protect them in their home community. And this is one of the ways that we can build hope. We've seen how it works in countries like the UK, where these clinics have been a beacon for communities. It really is, I think, a collective defiance against the injustice of this virus that has been going on for so long. And I think I will end there. Today is that period of time where we need to be heartened. We need to remember that hope is out there. We need to remember kindness and compassion, because that is what will get us through even this darkest period before the light. And I'll stop with the inspiring words. I was just amazed, the young poet, Amanda Gorman, at the presidential inauguration. And she said, "For there's always light, if only we're brave enough to see it, if only we're brave enough to be it." Thank you.
Thank you so much, Bonnie. On behalf of Queen's University and the School of Policy Studies, that was a wonderful introduction into this topic of balancing vaccine hope with pandemic reality. And I was just busy writing down, always light, you have to be brave enough to see it. So that's a wonderful comment to finish. There are a series of questions that have been asked as you presented. So I'll just highlight some of those questions and feel free to respond. One is more of a personal nature, since we just started with an inspirational finish. How do you keep going through this, as you've quoted, marathon, and how do you keep your batteries charged given the heavy burden that you carry?
I try and walk the walk, but yeah, some days are more challenging than others. I am blessed with having a team, and KIERAN knows this. In public health, you're never alone. We always have people to talk to. We have people to run ideas off, to learn from. And that is one of the things that keeps me going. I am very aware, acutely aware every day, that I'm the face and the voice of a big number of people, all of whom have put their effort and time into trying to manage this pandemic in the best way that we can. And that's one thing that is a bit of a burden in many ways, but also keeps me going. I'm also a runner, so that's why the marathon analogy comes to me. And although I don't run as far or as fast as I did even a year ago, I do try and get out and continue that. But it is so important. It's physical and mental health, and we have said from the beginning here in BC, go outside and play at least 30 minutes a day, and that is so important for us to find a little bit of joy every day.
Wonderful. Thank you for that. And what advice would you give concerned citizens who are bombarded with competing information, conspiracy theories as part of the infodemic, particularly when some of the competing information is coming from other healthcare professionals?
I know it's so challenging, and it is there's no right answer to, well, I shouldn't say there is some that is truly not true, and we do need to counter that with facts and make sure people know where to go to find credible information. And there's a number of sources: the Public Health Agency, we have BC CDC, you have Public Health Ontario, your websites. Making sure people know where to go, where there's a source of truth, and making sure that we are responsive to those questions that come up over and over and over again. And there's this whole misinformation, infodemic, and there's that truthiness to it. And some people are very good at that. They've spent a lot of time, when we look back at the anti-vaccine movement, they spend a lot of time weaving in things that are a little bit true into a narrative that is overall untrue. But it does arouse questions. So answering people's questions, and that's the thing about these new vaccine platforms. When I've been talking to particularly care aides and the healthcare workers in long-term care that were immunizing first, spent a lot of time talking to them and answering questions. What does this mean? You know, what can I expect? Is this real? Is it true that this happened in other places? So I think we have to have that knowledge, and then we have to answer people's questions quickly and truthfully.
Thank you. You also talked, well, about the marathon, and we certainly don't want to burn out pretending it's a sprint. But at what point will you be able to say and tell the citizens of British Columbia when the pandemic is over? So in 1918-19, how did that pandemic end? And how did people build immunity? And might we be immunizing for years going forward to try to limit the spread of this virus? A lot of questions.
I've come to learn that uncertainty is something that causes a lot of anxiety, and the reality is we still have a lot of uncertainty. And part of my challenge is making decisions in the face of a lot of uncertainty. So 1918 kind of petered out. It didn't really end. We reached a certain level of people being sick with the things we know about influenza, and we're now learning about coronavirus, this coronavirus anyway, is there's a seasonality to it. So that helps. If we can get cases low enough in the right season, then it peters out. Will it come back again the next year? That we don't know. How long will protection from the vaccine last? That we don't know yet. But this virus doesn't change. There are a lot of things that we have learned. And the genomics, the whole science of looking at whole genome sequencing and being able to understand what mutations mean, how fast the virus is changing, that's all revolutionary, and it's being shared in a way internationally that we have not had before, ever. So that helps us understand that this virus doesn't change as quickly as some of the other ones, like influenza, for example. So if we know that, we know how well these vaccines work, and we know that our body's immune system response seems to be going the way that we would expect it to go, it's likely that we're going to have protection from this virus for months to years. But we need to go months to years before we can confirm that. But I think we will be looking at this summer in Canada. We'll have enough people immunized, the virus will be less infectious, that we will get back to some sort of a normalcy. We won't be out of the pandemic necessarily, and I think that's probably another year before we have the information to really say that this is gone. But I could be wrong. I'd love to be wrong on that one. But I think by the summer, we'll be able to do a lot more things that are normal for us, spending time with more people, but still being very cautious. And we'll never, ever be able to stop washing our hands.
So Dr. Walker has family out in British Columbia, and he's very anxious to go visit, perhaps this fall. What does the fall look like for British Columbia if you had that murky crystal ball that you had to look through?
Yeah, the couple of things that I hope will be happening this fall. I want all of our post-secondary students to be back in university and in classroom, in class studies. That is something that we've heard from young people. And the people who have been most affected, other than our seniors and elders, have been young people, particularly at the transition phases in their life. So we look at people who graduated from university last year, and there's a young person in my life who did that last year, and my niece is graduating this year. The rituals and the social connections and the interactions that you have at that period in your life. And for many students, then you graduate and the job prospects aren't great, your social interactions are limited, and for many, university has been behind a screen and where they haven't connected with their university community. So I am hopeful that that will be gone by next fall. I think we will still need to be careful about, and we'll have to wait and see as respiratory season ramps up again, about large gatherings. So I think the last things to come back will be things like cruise ships, I hope, large conferences, where there's lots of people coming from various different places and coming together. But I think many other things will be back to much more what we're used to.
The Globe and Mail this is a question, the Globe and Mail has been reporting that the WHO representatives have been unable to ascertain the origins, given their 2 weeks of investigation to date. Do you have any ideas on the origins of the COVID-19?
Yeah, a good question. I have some theories just based on what I know around SARS, the first SARS outbreak, and but there's likely an intermediate species, but we don't know. And I think about Ebola, because we've known about Ebola since the 1970s, and they've done studies all over the place trying to figure out how Ebola gets into human populations and other places, and we still don't know for sure. But for many, many of these viruses, the common denominator at the end of the line is bats. So I suspect where there's bats involved.
Okay, thank you for that. The next question was just about public health measures. And clearly people pick up that there'll be different national approaches to public health measures as compared to the United States and Canada on just simple masking under one government. And now there are differential approaches to masking even amongst provinces. And they just mentioned about masking of children in school settings. Many times we don't have an evidentiary base to this. And how does British Columbia go about making those decisions and implementing them to best protect students, particularly in the school setting?
Yeah, so schools have been one of the more challenging things, I believe, for all of us across the country. And there's in decision making around crises like this, there's data, but data never tells you by itself, never tells you what to do. It's all in the context of values, of understanding, of sometimes small p political contexts, and judgments, and even setting a threshold, for example, of numbers of cases or whatever, is where the benefits outweigh the risks, is a value judgment. So it is something that we look at data. One of the things that we did early on, and this is something that I've been doing for quite a long time, is, as KIERAN knows, get involved in pandemic influenza planning, chairing a committee that has written the Canadian plan for the last number of years. So I've looked at data around school closures for influenza for many years, and we redid a lot of that information after seeing what people did in 2009 with the influenza pandemic that we had. And we know that children are amplifiers of influenza. So that was a concern last spring, when we put in restrictions and all of us across the country closed schools. So we wanted to understand, are children going to be amplifiers of this, or are they going to just reflect what's going on in the community? And I think we have consensus in the, at least in Canada, that children are not amplifiers in schools in the way that they do for influenza or in the community, but they do reflect the levels of transmission that we have in the community. The other thing that we did a survey, and we've been doing, following the research on, is what we're calling the unintended consequences, but the societal consequences of the public health measures that were put in place, and the impacts on families across the board, from children being out of schools, was devastating. And what that didn't matter whether your parents were in healthcare, were grocery store workers, work from home, across the board on all income scales, all races. People found that children being at home and away from in-class learning for that period of time was hard on children. It affected their learning, it affected their social, emotional well-being, and was hard on families. So our focus was to make sure that we could safely get children back into school as soon as we could. And that was, so that's a long way of saying masks were part of it, but there are many other pieces. And we know this from healthcare, with the personal protective equipment, PPE, masks are the last line of defense. So what we need to do is have those different layers that make sure that there's reduced numbers of people in the school, that you're in a cohort so that you're not in potential contact with 1,000 kids, you're in contact with a smaller number, that you have the same seat every day, that you, when you're doing group things, you take different precautions, all of those things. So I think you look across Canada, our mask policies in schools are relatively similar. It's all those other pieces that we have as well that support whatever mask policy we have.
Thank you so much. There's another question just about COVID-19. So we know there's an original strain of COVID-19. There have been some mutations. From those mutations, you then have variants. And how does our current testing test for variants? So perhaps you just speak to BC and perhaps recommendations of what we should do at a national level.
Yeah, so the tests that we're doing that are the most accurate, the gold standard, are what we call PCR tests. And they're the ones where we stick that big swab in the back of your throat, or though in BC we have a swish and gargle one that we use for young people particularly, but anybody now. And that's what it looks for is pieces of the RNA. So this is an RNA virus. It only has a single strand, about 30 base pairs of nuclear of genetic material, and it looks for specific pieces that it binds to, these PCR tests. And so that's the gold standard. It doesn't tell us if you have one of these variants, but what we have been doing from the very beginning in a number of provinces, including Ontario and BC, Alberta, and at the National Micro Lab and Quebec, is looking at what we call whole genome sequencing. So it really has moved ahead, this whole concept of whole genome sequencing and how we can use it to help understand the pandemic. So in BC, and I presented some of this in our modeling last week with some of the phylogenetic trees, we've been following this from the beginning. It takes time to do whole genome sequencing, and we've had to ramp up to do more of it. But what it does is say how closely related are each of the sequences that we get. So swab that comes from my nose when I'm positive and yours, and we look at are they the same or different? And this is how we early on realized that most of the cases that we were seeing in BC were coming in from Washington State, that we had this huge tsunami of cases from Washington State, because there's a lot of people that travel back and forth. And have connections across Washington State. We had a dental conference that had a different strain that had been introduced at that dental conference. And then people who worked in dental places are actually across the country. There's cases all over the country and internationally, and they were slightly different. Nowadays, what we're seeing is that these whole genome sequences are done by labs around the world, and they were changing by about 2 base pairs per month, which is pretty slow. In the UK, they were doing surveillance, and they found that there were some areas that had changed quite a lot. They found this new variant, so this cousin of the strains that were circulating for a while, that gave it some sort of advantage and allowed that virus to take over and start spreading more rapidly. And one of the things was this mutation on the spike protein. And they think it maybe means that the spike protein allowed it to bind more, to stick better to our ACE inhibitors, the binding, the landing places basically in our mucosas. So it would mean that fewer viral particles would be required for someone to get infected. And now we've used this whole genome sequencing to help us understand that those variants are here in Canada, and they are, not surprisingly, because this virus is transmitted from people. When people move, they bring the virus with them, or they pick it up in the places that they're going and they take it home with them. So we've seen these variants, and we use whole genome sequencing to help us understand them. But we've also now created a new part of the PCR test that we can screen for the particular part of that mutation that we're worried about, the 501Y. So in Ontario, now in Alberta and here in BC, we're using that screen to say which are the ones that are most likely to be a variant, and then we screen those to do the whole genome sequencing. So that's what's happening right now. That's how we're going to have a better understanding. When I talk about us being in that difficult position of needing to buy time, it's so that we can do that type of testing and understand better how many of the variants are circulating. Are they getting a toehold? Are they going to start taking off as we're still getting vaccine out there?
So another question that follows along that line is, given that there are variants now, and that our vaccine strains were made based on the mRNA of that original strain, do we have to change our strategy? And if so, how quickly can we do it?
Yeah, so this is the other thing that I think is so amazing about these mRNA vaccines. And I don't know, KIERAN, if you feel the same way, but they're manufactured. So yeah, you can change them. So they are designed to be the code that our body to make the spike protein. And we know that one of these variants, the thing that might make it more transmissible, is a change to the spike protein. So far, what they've done is look at, are people who have, and are people still being protected are they still developing enough antibodies that will protect them from the variant strains, that different spike protein? And the mRNA ones seem to be holding their own. Where we've seen a challenge is the AstraZeneca vaccine, which is a viral vector vaccine. And that was the one that was used in South Africa, where it doesn't seem to be as effective at preventing people getting infected with that strain. And it may be because there's another mutation, or just where the change was, that your body's immune system, those antibodies that we develop, don't bind and don't neutralize that spike protein as effectively. So that's a bit worrisome, but they can be changed. And that's the neat thing about these new manufactured platforms. So they are looking at whether they need to be changed and how quickly that can be done. So it may be that we immunize everybody that we can with the vaccines we have now, and then give them a booster dose with the new slightly changed one.
Well, I'll put that under balancing vaccine hope with the pandemic reality. Yeah, the innovation and technology has been amazing, and they are safe and effective vaccines. So another question just off YouTube was just about the lockdown. So Ontario, our region is just coming out of lockdown in southeastern Ontario. We're moving to green today. Other regions may be opening up as well in Ontario, but there's tremendous resistance from communities to staying in lockdown, and tremendous frustration, the negative impacts, as you've discussed, both mentally, socially, physically. How has BC differed in their approach? And have you had to go in lockdown as severe as other jurisdictions? And how do you balance the freedoms of individuals versus the threat of the pandemic?
Yeah, that is a challenge that I think we all face in our world in public health. And it is really the ethical principle of doing just enough, but not too much. And it's impossible to find just enough most of the time. And so sometimes we end up getting behind and having to do more than we wanted to do. And there's some things that we were learning from the very beginning. And, you know, I've said this before, when you're dealing with a virus that we still don't know everything about, and that is causing the amount of death and severe illness and complications, even for young people, that we need to err on the side of doing too much rather than not quite enough. But that's a really challenging thing. In BC, we did a lot very early on and took a number of very stringent measures very rapidly, and that made a difference for us. And part of it was timing, part of it was luck, part of it was the approach that we took. In the summer, we were able to open up quite a bit more. But as the virus transmissibility changed again, particularly in around November, we ended up having to put in place more restrictions. But we've never had to go to that sort of full lockdown since we started our reopening last May. And one of the key things that we use here is a simple thing called, I did a public health order that requires every organization to have a COVID safety plan that is public. And we use that as a way of making everybody say, what does it mean for me and my business, my office, my school? So the schools have very detailed COVID safety plans. Every restaurant has to have them. So we've put in restrictions that affect these COVID safety plans. And when our public health inspectors go in, they can say, okay, how well are you meeting this? It's not perfect by any means, but it's helped us identify the areas that we need to focus on and where attention needs to be focused. It doesn't mean that we got everything right, and we still are seeing transmission, and we're trying to deal with those. So we have a workplace team that looks at where are the things that the plans are falling down on. And we've tried to approach it that way. When we had nightclubs, it's a long story, but nightclubs were open and we were seeing lots of transmission in them because by design, people go to a nightclub to drink, and when they drink or to be entertained and go with other people, all of those barriers like staying in small numbers and all of that stuff. So we worked with industry to try and put in restrictions, but they were not able to manage. So we had to close those down. But with restaurants, we have very strict restrictions on what you can do and how long you can stay open and all of those things, and manage. And when we see cases being transmitted, we look at where it happened and try and address those issues. It's not perfect and it's not easy, but we've been able to manage that balance for the most part. But it also means that we have transmission that's ongoing, mostly in younger people. Our hospitalizations are coming down. People in ICU are coming down, and thankfully, our long-term care outbreaks and deaths are coming down dramatically.
Well, the same trends in Ontario, luckily, so very happy to see that change. This is somewhat in follow-up from our website. So what are the techniques that you're using to try to balance science, and obviously you're a scientist, you're science-based, and the politics of the pandemic? So clearly you have to convince a cabinet and a premier, or in my instance, I have to convince a board and others. How do you make that work, that they listen to science, they hear your voice, and it's a negotiation, it seems. How's it worked in BC without giving away trade secrets?
Yeah. It's funny, I've been called stubborn recently, and I don't think of myself as stubborn, but my ex-husband might agree. You know what? It is very much a balancing, and it's based on relationships and trust. And I was relatively new to this position as the Provincial Health Officer. My dear mentor and long revered Provincial Health Officer, Dr. Perry Kendall, just retired a couple of years ago. But so it was very challenging. But there's a couple of things I think that we need to think about when we think about leadership. One is you have to know your stuff. And you have to have confidence in the science, in understanding what you do and what you know. And I rely on my team of public health experts to make sure that the BC CDC, the chief medical officers of health, the MHOs in my community, and across the country, the chief MHOs across the country, we have our own therapy sessions every Sunday morning where we exchange information and talk about things. So partly it's being an expert, knowing your stuff and knowing how to communicate it in a way that the political leaders understand. And I have tremendous respect for the political leaders. That is their job. They are elected to make those decisions. It is my job to say, this is what I believe we need to do. The advice that I give is about best protection of the public's health. And I know that needs to be balanced, as I said, with many other considerations. It's not just about the data says this, it's about where does that fit? What does that mean? So we have developed very strong relationships of trust. I have to say that the Deputy Minister of Health that I work with, Stephen Brown, he and I talk very regularly, but early on in this, being able to talk through with him, this is what I believe it means for the health system. This is what I believe it means for public health. And having that relationship with the Minister of Health here as well. And then we take that to cabinet and to the premier. And so it was building that confidence. A little bit of it is courage, being courage to stick with your convictions, even when it's unpopular or when it's uncertain. And I would say some of it is compassion, being, it was, I think, a different approach when in the media, when I was talking about kindness and love and about how we needed that, because this was going to be hard and we needed to minimize the trauma on all of us and build resilience. And you do that through kindness, through kin, through recognizing that we're in this in a different way and that we are all managing and we need to support each other and not push others away. And I'm just very grateful. I've not had political interference, definitely had some very tough political discussions with the people who absolutely are the ones that are on the hot seat to make those difficult decisions.
Well, I'm not going to say that you were stubborn. I'm going to say you're courageous. I like courageous better. So that's very nice adjective. The other questions that are just coming up are just about the vaccine. So it appears that some countries are way ahead of us, and everyone's citing Israel and United States rates of immunity through immunization are increasing. What do you think Canada could have done differently in terms of negotiating access to the vaccine earlier? And some of the vaccines aren't as effective as others, and yet they'll all be available to the public. How do we deal with that varying, quote unquote, effectiveness or efficacy of the vaccines?
Yeah. So, I think there's going to be lots of time. I've said this before many times too. Lots of time for the recriminations, the class action lawsuits, and the public inquiries. So, we were all dealing with a world of global uncertainty. So the federal government did the best they can, and they signed contracts with 7 different vaccine manufacturers. I think the world was taken a little bit by surprise that these vaccines were available as early as they were. And it was, the fact that they're so effective is also, quite unexpected perhaps, but really amazing. So one of the reasons the phase 3 trials didn't take as long as was expected. So nobody thought that we would have a vaccine before January at the earliest. But because we had that huge surge of cases, particularly in the UK and US and Brazil and places where these studies were being undertaken, that meant that they got the number of cases that they needed to see if there was a difference, between vaccine and placebo very early on. It didn't take as long to get people into the study and to have disease accrue so that you could tell if there was a difference. And so that meant that vaccines were available earlier than people thought they would be. So it is what it is. Part of the reason for that as well was the interval that was used, 21 days or 28 days is really short for an interval for a prime boost vaccine. Normally you would wait, if this was not a pandemic, we would wait, they would generally be somewhere around 3 months before you, or 2 or 3 months before you get the booster. But they wanted, and that's one of the reasons why we're quite comfortable extending that period of time for the booster. If we could do something differently, things that I know from my work, and you know this too, KIERAN, is that we don't have a domestic vaccine manufacturer. And historically, Canada has been one of the leaders in some vaccine development. We even look to the polio vaccines, the technique for growing the virus to be able to develop the vaccine came from Connaught laboratories, from Canadian researchers. And the nanoparticle that holds in our mRNA vaccine is a Canadian researchers here in BC that developed that capacity. We had for many, many years one vaccine manufacturer left that created the influenza vaccine, but unfortunately they were sold to a larger manufacturing company or a larger pharmaceutical company, and they moved offshore. And there was not an investment as in Canada in vaccine development, vaccine research, until very recently after the pandemic in in 2009, the Canadian Influenza Research Network, and that morphed into the Canadian Research Network, CERN, was created. So we've in a very limited way started to move into that, but we don't have domestic production. We need that now. I think we've learned that. We've learned that in a crisis, people keep things close to them.
Both for personal protective equipment as well as for vaccines. Yeah, we need a domestic.
Yeah. And for low dead space syringes and for, things, who knew?
Yeah. So one of the comments was that Prime Minister Trudeau has said that we have a goal of vaccinating all Canadians who want the vaccine by September. Do you think that's realistic? Is it achievable given the timeframes?
Yeah, and so this, I forgot the second part of your question was around, different vaccine efficacy. And I think we have to remember when we set out the a priori criteria that the WHO and others set out that we all agreed to was if the vaccine prevented disease, I believe we said 60% of the time, that would be really good. And that's what we have with influenza. And that would make it a good vaccine that would help us get through this pandemic. And we've seen with influenza, if it's the influenza pandemic 2009, we had actually a very effective vaccine, but once you started to get people immunized, rates fell off really quickly. So all of the vaccines that have been approved for use around the world right now have really good effectiveness. If we look at AstraZeneca, which is the one that's less effective than the mRNA vaccines, it's challenging to compare them because the studies were done differently and the data was collected differently. So you can't sort of say one against the other, but it appears that it prevents serious illness about 70% of the time. It wasn't done there was not a lot of people over age 60 or 55 even over in the studies for AstraZeneca. So we really don't know if it works that well in older people, and the studies show that it might not. So it's one that does still work quite well in younger people. So ages 18 to 64, we know it's about 70% effective in preventing you from feeling sick or getting severe disease, and even higher from ending up in hospital or dying. So that's a good vaccine. What we've been challenged with, or the bright spot, is that we have these messenger RNA vaccines that are like 95% effective, even in older people. And that's like miraculous and wonderful. So I think what we need to think about is who to best use these in. We have limited supplies at the front end of these vaccines that work well in older people. So we need to use them to protect older people. But we may have more supply in the short term of these vaccines that work well in young, healthy people. So let's target young, healthy people with those vaccines. And I also believe, and there's no data yet, but it's coming, that we will likely be able to give people a first dose with AstraZeneca or Novavax or the Johnson & Johnson vaccine, and a booster with an mRNA vaccine when we have a whole bunch of it in the summer. And the UK's just started a study on that to look at mixing and matching in dose intervals.
And did we touch on the goal of September?
Oh, and yeah, I'm also an optimist, but I think, yeah, we're going to get there. I think there's going to be a period of time if things continue the way they are, and the whole Pfizer scaling up, Moderna is looking at how they can get more doses in the vial, so that reduces the number of vials that they need to procure. AstraZeneca is giving the ability to produce that vaccine to many countries. India is producing it in large numbers. So I think we're going to get there. Some of the vaccines that didn't work, the manufacturing companies are now partnering with vaccines that did work to increase production. So I think by the time we get to the summer, we have age groups in BC that we're looking at that are due sort of September for their first dose. But I think once we get to having a whole bunch of vaccine, we're going to be able to give it to lots of people very quickly.
Very good. Well, there's a compliment here. Someone that lives in BC is very inspired by your patience, your compassion, and your wisdom. It must be a very challenging position, and they very much appreciate your leadership. Just talking about leadership, there may be public health physicians, future public health physicians listening. Any advice on risk communication to the public, leadership styles, what works, what doesn't? And certainly,
Run away.
it has many activities, and I watch you to learn risk communication strategies and try to slow my speech down because you speak so well and clearly. So any
You know, I think I learned from watching other people. Dr. Sheila Bowser, who I mentioned, who was a master communicator, and recognizing that that telling people why you're doing something, giving them the background, giving them the technical information, you know, being able to talk about the models and what they mean and don't mean in a way that that people understand. I think more than anything, I've learned that words matter, and that if we trust people with as much as we know and are honest and open about it, and you give people the means, so you tell them, here's what we're hearing and here's what it means, and here's what I need you to do, and give people the means to do it. And that's the hard part. So, you know, I need people to stay home when they're sick. Well, if I'm a shift worker at a poultry plant, where I'll just lose my job and they'll replace me if I don't go in, and it's only a mild cold and it's probably not COVID anyway, you know, I don't have the means to be able to protect the other people in my workplace. And I live in a crowded home with my multi-generational family. So we need to give people the means to do what we need them to do. And that's, you know, part of my job, and our job in public health is to help civil society, but also governments say, well, this is what our aim is. How do we support people to be able to do that safely? And so, you know, all of that is about leadership, and I guess again, you know, compassion, recognizing that the needs of others are important, and also talking about how we can, using language, using our position to overcome those inequities, or those things that people see, those othering of people. So I'm very cautious in how we report, you know, who is infected with what, and talking about people in a way that they can't be personally identified. Because even now, there's such a stigma associated with this virus, and you know, people get nasty notes and letters and stuff. And so, trying to appeal to people's altruism and better angels, and that works.
Thank you so much for that. Just trying to get into the philosophical approach that you've had in British Columbia. There is control of the disease, there's elimination of the disease or infection, and eradication or extinction. What approach did BC have initially in trying to limit the spread? Was it one of control or elimination? And did that affect your approach to public health measures? And did you want sudden hard measures that closed and limited the spread of infection? Just if you could discuss that with us.
Well, you know, I'm a control freak, so that was option number one. Yeah, you know, having been through SARS in Toronto, I actually, you know, was hopeful early on that this is a virus that we would have been able to, you know, move back and push back into nature, like we did with SARS in globally in 2003. It became clear to me, I think the aha moment to me was really when we had a person who we identified who had traveled to Iran. And that was in a sea of, oh, it's still in China, it's still in China, it's only in China, and it's travelers from China. And suddenly there was somebody in Iran. And you know, that to me was an indicator globally that this virus was spreading in ways that were way beyond what we saw with SARS in 2003. So then it became, okay, it's inevitable, it's coming here. We need to keep it out as long as we can, to try and for us here in BC, that was, well, here in Canada, that was to try and push it out as long as we can, to do the contact tracing, to keep those chains of transmission down until we knew more about how it was being transmitted, till we understood more the dynamics of the virus, and till we got to spring where it might not be as transmissible. That was the hope from other viruses like influenza, and so that we could get through influenza season. If you remember last February, March, we were peaking in our influenza season. So that would have overwhelmed our hospitals if we hadn't taken a dramatic action then. So the dramatic action was to try and stop it as much as we could and see if we would make it to the end of respiratory season, if it would go away, like we see influenza go away pretty much in the summer. So once we got to the summer, again, it was looking at what was happening and the fact that it was down, but it wasn't going away. And then our approach here was to look at how do we have just enough so that we can get as much back in society as we could without giving the virus opportunities to spread widely and wildly. So we had restrictions in the summer that were less than we were trying to find that balance. And the idea was to open up just enough and to pull back if we needed to in those settings where we saw transmission happening. And then as we went into fall, we were trying to keep with that balance. But then with the increased infectiousness, the safety measures we had in place just weren't enough anymore. So we imposed additional precautions. And now I think we need to live with this virus. I think it's unlikely it's ever going to go away. What I hope is it will become, once we have enough people immunized, that it's not going to be spreading in large clusters and outbreaks and overwhelmingly spread in our communities, that maybe it will mutate again to become less severe, like other coronaviruses that we see circulate every year.
Well, thank you for that. Just because you mentioned influenza, there's been several questions about what happened to influenza in the dual pandemics or epidemic and pandemic. So any comments on why we haven't seen much influenza this year?
We've seen none, zero. I mean, like it's miraculous. It's going to put all those flu people out of business. No, you know what? It really, I believe it's a couple of things. One, it's we're not traveling as much, and particularly international travel, and we know that that's what brings influenza in every year, and there's a circulation that happens. But also those measures that we put in place, staying away from each other. Particularly, kids staying away from each other does mean that we don't transmit viruses, including influenza virus. Some of the more easily transmittable cough and cold ones, and we still see a bit of, but nothing like we usually see. So the cleaning your hands, covering your mouth when you cough, the wearing of masks, the distancing that we're keeping, the not having crowds and groups come together and then spread out and move around the world. I think that's the number one biggest thing.
Another question, Bonnie, was whether you had any time off that last year. People are worried about
you. I have to say my sister, who lives in Toronto, who's actually home in Prince Edward Island and has been there for several months with my parents because they're older. So she came out, I had 1 week that I took off in August. And my sister's in publishing and she's quite brilliant. And so she chained me to a desk and we wrote a book. So but it was really, in some ways for me, it was cathartic because it was talking about the thoughts that we had and what we were going through. She happened to be out here for March break when the pandemic started. My younger sister and my niece and nephew had all come out. We had been planning this for years. We were going to go to a Canucks game. Anyway, the pandemic, they arrived on March 13th, and it was the day after the pandemic was declared, and I shut everything down and sent them home. So I am looking forward, though, to once we get through this challenging time, that to just take some time to sleep, relax, and travel again. I can't wait to travel again.
Well, we'll have to watch the variants and where they are,
Yeah.
actually. The other question was, I think there's many health professionals listening in this afternoon. They're wondering about the conversations about those that have questions about the vaccine that might be hesitant, and how to build confidence in those individuals so that they accept being vaccinated. Obviously, considering this is a voluntary vaccination strategy. Any guidance for health professionals and or the community?
Yeah, I think acknowledging that it's normal to have a lot of questions about these new vaccines, and I certainly did, and then engaging with people and answering those questions. There's lots of misinformation, particularly on some of the social media streams, and certain ethnic groups we're seeing, and racial groups we're seeing have been targeted with different misinformation. So we've tried to spend time addressing those, but just talking to people. And we still know that the people that people listen to are their physicians. They listen to elders and seniors in their community. And the other part that I think is incredibly important for us is monitoring safety. And I talked about a little bit about how we do that, but being able to put that data out there and say, look, there's millions of people now who have received this vaccine, and all of us are sharing information, and here's what we're finding, and people are okay. And we're seeing that. I was talking with my colleagues in our First Nations Health Authority, that I engaged with them, and we talked with the elders in many of the communities, the elected leaders and the hereditary chiefs. And it was engaging with the elders to tell stories about the importance of this, and then having elders themselves receive the vaccine made a big difference. So I myself received vaccine when I thought there was a lot more coming more quickly, but part of that was because I was asked by many of the care aides, in particular from long-term care homes, who were first in line, and they're like, well, will you get it? So I did receive it publicly, but it was a message of solidarity with our healthcare workers and to answer their questions.
I'd be remiss if I didn't ask more of a policy question, given this is School of Policy Studies at Queen. And there's just a question on governance and federal, provincial, territorial partnerships, how effective that governance model is at responding to a rapidly changing pandemic, given the bureaucracies and the authority over health, etc. So any comments generally on how we can improve our loose-knit federation?
Yeah, oh, good question, huh? If I knew the answer to that, I will tell you that at a number of operational levels, it worked incredibly well. And I talked about our group therapy sessions on Sunday mornings. We set up a special advisory committee very early on of the chief medical officers of health from across the country. I was chair of the chiefs at the time, so myself and Dr. Teresa Tam. And we met daily for many, many months. And now it's 3 times a week. And we, so that we have some consistency in our public health approach, that we have the data that we need, and we try and there's a number of different pieces that go into that. So that part has worked well. And I do think we're a federation, and sometimes coming to consensus is challenging. We've seen that with every crisis that we've had to deal with. But I also think there's a strong sense of connectedness and goodwill in our country that we need to keep, and solidarity with each other. And those are the things that will help us through this. And as I said before, there's going to be lots of time to pick it apart and find out what didn't work in the future.
Well, I think we're coming to the end of our presentation. It's 2 minutes to 6 Eastern Standard Time. And I can't thank you enough, Bonnie, for spending an hour and a half in the School of Policy Studies, answering questions and presenting the Duncan G. Sinclair Lecture, Balancing Vaccine Hope and Pandemic Reality. I very much appreciate you answering so many questions from our audience, and the presentation that you gave. It certainly honors Dr. Sinclair and his leadership at a provincial and national level, and can't thank you enough for your compassion, your caring, your risk communication, and your ongoing mentorship to all public health physicians in Canada. Deeply appreciated.